All right, everyone, we're going to go ahead and get started. Again, a reminder on the screen, whether or not you're here actually present with us or watching on Blackboard Collaborate, you can go to the website that you see on the screen, enter the hashtag cardiology, and you'll see a fun introductory question. But Drs. Mouradjian and Plazik will be using this throughout their presentation as a way to interact with you all, and so we'll be referring to that. There's also an option to enter any questions you may have throughout the presentation on the app, so you're welcome to submit questions using the app. And then in addition, you're obviously welcome to raise your hand and ask questions. So without further ado, it's 12:31. We'll go ahead and get started. I'm going to introduce both of our speakers now. First up is Dr. Mallory Mouradjian, and she did PGY1 here and decided she liked Maryland so much that she stayed on for PGY2 in cardiology. And the title of her presentation is Weighing the Evidence, Direct Oral Anticoagulant Use in Obese Patients. And then at 1 o'clock, Dr. Michael Plazik will take over. He too did a PGY1 here and is Dr. Mouradjian's partner in crime within the cardiology program. And he's going to be talking on pressing our luck, pharmacotherapy for complex shock states. So without further ado, I'm going to hand it over to Dr. Mouradjian.
Good afternoon, everyone. As Dr. Knoll just mentioned, I will be presenting today on the direct oral anticoagulant use in obese patients. I think this is an interesting topic, and it's something that had come up a couple of times during my PGY1 on rounds, and it's always usually a bit controversial. So before we get started, I wanted to kind of poll the audience and see what the general consensus is on using DOACs in obese patients. You can use your Slido app and answer on here. So have you ever recommended a DOAC for an obese patient? Yes, I recommend DOACs for obese patients regularly. I recommend DOACs for obese patients, but only if it's the only option. And then no, warfarin is the most appropriate choice for obese patients. Okay, so it looks like generally, at least some of the time, patients, the audience members feel at least somewhat comfortable prescribing DOACs in obese patients. Hold on just a moment. So for the audience members in the room that had stated that they're okay with prescribing DOACs, which DOACs have you recommended in obese patients? So we have some votes for Pixaban and some for Rivaroxaban and none for really any of the others. So we'll just keep that in mind as we go through some of the data today, and we'll get started. So before I get started, I have no conflicts of interest to disclose regarding the content of this presentation. And the audience members by the end of this presentation should be able to identify pharmacokinetic and pharmacodynamic changes in direct oral anticoagulant or DOAC exposure in obese patients. They should also be able to evaluate current literature regarding the use of DOACs in obese patients, and then given a patient case, be able to provide an evidence-based therapeutic recommendation regarding the use of DOACs in a specific obese patient. So obesity is highly prevalent within our society. Up to 40% of adults in the United States and 30% of adults in the state of Maryland are considered obese. So that means in your day-to-day practice, you're very likely to encounter obese patients. The World Health Organization classifies obesity as being a BMI greater than or equal to 30, and then further subclassifies obesity into class 1, 2, and 3, with class 3 being the most severe form of obesity of a BMI greater than or equal to 40. Obesity is also a prothrombotic state. So the fat cells within your body are constantly releasing inflammatory cytokines that lead to a state of chronic inflammation as well as impaired fibrinolysis that leads ultimately to a state of hypercoagulability. And that, in addition to the sedentary lifestyle that some obese patients may live, and the kind of stasis of blood flow that would thus ensue, puts obese patients at increased risk for thrombotic events. And we see that obesity is considered an independent risk factor for both venous thromboembolism and atrial fibrillation. So again, those patients that the obese patients that you're commonly encountering in practice are often going to require anticoagulation. We generally think of the DOACs, or direct oral anticoagulants, as being a preferential option for many patients for atrial fibrillation and venous thromboembolism because they're safe, efficacious, and they're a lot easier to use in general than warfarin. However, there are some concerns regarding the use of DOACs in obese patients, and a lot of this stems from pharmacokinetic changes that you see in obese patients. So there are two main pharmacokinetic parameters that obesity really affects, the first of which being volume of distribution and the second being clearance. So first, talking about volume of distribution, which we really use effectively in practice to tell how much a drug distributes into the tissues. You can see here on the left side of your screen a kind of a simplified two-compartment model of a patient with a normal BMI. So you can see the central compartment, which would be composed of the blood and the interstitial space, really your hydrophilic areas, and then the peripheral compartment being your tissues and adipose tissues. So in a patient with a normal BMI, if you give them a lipophilic drug, it'll fill up the peripheral space and then also go on to fill up the central compartment. In an obese patient, how this really changes, you don't see a big change in the central compartment and in the actual blood volume, but you see a much greater peripheral compartment. So again, if you're giving a lipophilic drug, it'll fill up the lipophilic peripheral space and then go on to fill up the central compartment. So overall, you can see there's a much larger volume of distribution for lipophilic drugs in obese patients. The second pharmacokinetic parameter that you really see a big change in obesity is clearance. So there have been numerous pharmacokinetic studies that have found that with an increase in total body weight, there's also an observed increase in clearance of drug. So this is really kind of simply represented in the figure that's on this slide. So you can see on the x-axis, total body weight in kilograms, and then clearance represented on the right-hand side of the slide. So with an increase in total body weight, there's an increase in clearance. One of the main hypotheses cited for why this occurs is that obese patients experience obesity-related glomerulopathy, which is really the phenomenon that obese patients have anatomically larger kidneys, which leads to more blood flow to a larger surface area, which increases filtration. So overall, the bottom line here is that clearance increases for renally cleared drugs in obese patients. So keeping these pharmacokinetic changes that I just talked about in obese patients in mind, and looking at some of the pharmacokinetic characteristics of the available oral anticoagulants, you can see here listed on the side are the 4 DOACs, so edoxaban, dabigatran, apixaban, and rivaroxaban, and then our more traditional oral anticoagulant warfarin. So directing your attention to the volume of distribution column, you can see that edoxaban has the largest volume of distribution out of all of the DOACs. So you'd expect the overall exposure to be most affected for edoxaban in obesity compared to the other DOACs. And then again, similarly looking at renal clearance, dabigatran and edoxaban are the most extensively renally cleared out of all of the DOACs. So again, their overall exposure would be most affected in obesity. And then looking at warfarin, the volume of distribution is actually smaller than all of the other DOACs, and that likely has to do with their large proportion of plasma protein binding. And warfarin is also not extensively renally cleared. It's mostly cleared through the liver. And so both of these characteristics would lead you to believe that there would be less changes in overall exposure in warfarin compared to the DOACs. And that combined with the fact that you can monitor an INR for warfarin is why many providers feel more comfortable utilizing warfarin in obese patients. So I'm going to direct your attention back over to Slido. So based on some of the concepts that we just talked about, which drug would you expect to have the most change in overall exposure in obese patients based on the following pharmacokinetic parameters? So a drug with a large volume of distribution, low proportion renal clearance, and it looks like it's pretty unanimous that it's a large volume of distribution with a high proportion of renal clearance, which is the correct answer. And you'd be concerned for a lower exposure if a drug had these characteristics in obese patients. So based on these pharmacokinetic changes, the theoretical pharmacokinetics that we would see in obese patients, there have been some pharmacokinetic analysis performed for each of the DOACs that kind of looked at overall exposure. So first, looking at some pharmacokinetic data for dabigatran, we have a subgroup analysis of the RELY trial. So the RELY trial was a phase 3 clinical trial that had looked at dabigatran versus warfarin in atrial fibrillation. And they went back and looked at the subgroup of patients in that trial that had an available peak or trough value at steady state in the dabigatran group. They then stratified those patients based on their body weight. So they had a low weight group, a reference weight group, and then a high weight group defined as a body weight greater than 100 kilograms. And then when looking at the mean trough for the reference body weight group versus the high body weight group, what they found was that the mean trough was 21% lower for the high body weight group compared to the reference body weight group. So there was lower levels observed in this subgroup within the RELY trial for dabigatran. We also have a pharmacokinetic analysis looking at apixaban, and this was a prospective pharmacokinetic study looking at 55 healthy patients, and they again stratified them based on weight, kind of in a similar manner to the previous study. However, their high weight group was considered greater than or equal to 120 kilograms. The patients in this study were administered a one-time dose of 10 milligrams of apixaban on an empty stomach, and then subsequent plasma concentrations were collected in order to elucidate pharmacokinetic parameters. So looking again, they looked at Cmax, AUC, and apparent volume distribution for the reference body weight group versus the high body weight group, and what they found overall was that Cmax and AUC were 20 to 30% lower for the high body weight group compared to the reference body weight group. So again, there was decreased exposure for apixaban in the high body weight group compared to the reference body weight group. And then in a very similarly conducted trial for rivaroxaban, again, a prospective study looking at healthy subjects and stratified based on their weight. These patients were also given rivaroxaban 10 milligrams one time, and then this was given with standard breakfast to increase absorption, was given with food to increase absorption. So what they found, again, looking at Cmax and AUC to kind of elucidate what the overall exposure was, they did not find any statistically significant difference in Cmax or AUC between the high body weight group and the normal body weight group. So for rivaroxaban, potentially there's not a difference in overall exposure for obese patients. And then looking lastly at a more recent and kind of real-world pharmacokinetic analysis of the DOACs. This was a retrospective review of 38 patients that were seen in an anticoagulation clinic. All of the patients were considered obese based on a weight of greater than 120 kilograms. They were prescribed a DOAC, and they had a steady-state peak concentration available in their records. The endpoint that the authors had decided to look at was the proportion of patients with a peak plasma concentration falling below the usual on-therapy median trough level. So the reason they decided to look at this is because we don't necessarily have therapeutic ranges for DOACs. So they looked at, they decided that patients that had a peak value, which was lower than what you'd expect the trough to be, you could say in these patients that their overall exposure was low enough that it could be clinically significant. So looking at what DOACs were actually prescribed in the trial, most patients were prescribed rivaroxaban, followed by dabigatran and apixaban. Notably, no patients had been prescribed edoxaban. You can see here the reference trough that they used from the previous pharmacokinetic studies that had been conducted as their reference group, and then the median peaks that they had obtained as well. And then looking at their primary endpoint, which is the peak below the reference trough, only 2 patients in the study had actually fit this criteria, and both were in the dabigatran group. So this represents 20% of the dabigatran group. And keeping in mind that this is a retrospective study, looking at a very small number of patients, it does raise concerns about using dabigatran in obese patients. So to kind of summarize all of the PK data that we have available for each of the DOACs, there's currently no pharmacokinetic data available specifically looking at edoxaban. Dabigatran and apixaban appear to have lower exposure in obese patients, and rivaroxaban concentrations and overall exposure appear to be unaffected by obesity. So now moving on from just looking at levels and kind of overall exposure in patients and moving on to looking at clinical outcomes, what type of clinical data do we have available for the DOACs? Unfortunately, there have not been any prospective or randomized controlled trials looking specifically at the use of DOACs and the efficacy of DOACs in obese patients compared with normal body weight patients. What we do have available, though, are subgroup analyses of the phase 3 clinical trials for DOACs. So you can see here listed are the phase 3 clinical trials that had looked at each of the DOACs in comparison to the gold standard at the time, which was warfarin, and then in each of the indications, so atrial fibrillation and venous thromboembolism for each of the DOACs. There was at least a small proportion of obese patients included in most of these studies. And you can see it ranged anywhere from 12% up to the most in the Aristotle trial, which was 40%. And again, most of these trials, with the exception of the ENGAGE trial looking at edoxaban, did perform a subgroup analysis looking at their primary endpoint and seeing if it was affected by obesity. One limitation that I did want to just point out was that if you look at the obesity weight or BMI cutoff in all of these trials, it varies what they use in each of the trials. So some of them use BMI, and some of them use an absolute body weight cutoff. So it makes it a little bit difficult when you're trying to decide in clinical practice what's considered an obese patient, because there's not been a standardized definition of obese patients in these trials. So Domino and colleagues conducted a meta-analysis of the phase 3 VTE trials for each of the DOACs to make it a little bit easier to decipher some of this information. So listed here on the slide is the forest plot looking at the primary endpoint in these trials, which was recurrent VTE or VTE-related death, specifically for the obese subgroup in those trials, and comparing DOACs to warfarin. And what they found overall was that the DOACs were still considered non-inferior to warfarin in terms of preventing recurrent VTE or VTE-related death in the obese subgroup population. Similarly, they looked at the safety outcomes that were available if there was a subgroup analysis available for the safety outcomes, which was major or clinically relevant non-major bleeding for each of the trials. So you can see for the Einstein trial, which looked at rivaroxaban, and Hawkinside trial that looked at edoxaban, it was considered non-inferior in terms of the bleeding endpoint compared to warfarin, even in the obese subgroup. And then looking at apixaban in the Amplify trial, they actually found that it was had a better bleeding profile compared to warfarin, which is similar to what they found in the overall analysis in the actual trial itself. So based on these kind of limited clinical data that we have available for each of the DOACs, what recommendations do we have regarding the use of DOACs in obese patients? So if you looked at each of the DOAC package inserts, there's currently no recommendations regarding weight cutoffs or dose adjustments based on weight. The CHEST guidelines for atrial fibrillation and VTE also do not offer any recommendations or restrictions regarding the use of DOACs in these patients. And then the only really societal guideline kind of recommendation that we have is from the International Society of Thrombosis and Hemostasis. So they actually recommend to avoid DOACs in all patients with a BMI greater than 40 or a weight greater than 120 kilograms. And they say that, and they go on to recommend that if DOACs are used in this patient population, then they recommend monitoring drug-specific assays to obtain concentrations. And they say that if the level falls within the expected range, you can continue the DOAC for that specific obese patient. And if the level is below that expected range, then you would switch to warfarin. So based on the fact that the only societal guideline that we have recommends monitoring for DOACs if you're going to use them in obese patients, I wanted to take a poll to see if this had been incorporated into any of your practices. So have you ever recommended therapeutic drug monitoring for an obese patient taking a DOAC? Okay, so we've had a few patients that have said yes, and then it looks like kind of the vast majority have said that they have not done this. And although it is recommended in that guideline, I think there's some issues that we'll go into with the feasibility is probably why most people have not recommended getting the level for patients. So when actually talking about monitoring for DOACs, what does this mean? So you'd be obtaining a peak concentration 2 to 4 hours after the dose is given at steady state. And you can obtain a concentration via a couple of different methods. So the most reliable method, of course, would be mass spectrometry, because you would be actually obtaining the actual concentration of the drug in the blood. However, this can be complicated, and it's often not available at many institutions. The other option would be obtaining anticoagulation tests, so anti-factor Xa and then Eckerin clotting time, dilute thrombin time, to be able to back extrapolate and find out what the concentration of the drug would be. Keeping in mind that these tests need to be calibrated for the specific DOAC that you'd be trying to obtain the level for. So although you may have anti-factor Xa available at your institution, oftentimes it's calibrated to heparin or enoxaparin and not necessarily to one of the DOACs. And then once you have that concentration, the peak, you would correlate it with usual on-therapy ranges. And if it's outside of that range, basically the recommendation is to switch to warfarin. So on here, I have kind of what the usual on-therapy ranges for many of the DOACs and at some of the more commonly prescribed doses. So you can see here that the ranges of these on-therapy ranges are often wide and often overlap from peaks and troughs. So it kind of gives you an idea that monitoring concentration might not be the most accurate way of deciding if somebody is therapeutically anticoagulated. I also just want to take a moment to just also reiterate that these are just the usual on-therapy ranges. So the ranges that are found in pharmacokinetic studies at peak time and trough time, and they're not necessarily tied to any clinical outcomes. And then lastly, I wanted to take a moment to kind of talk about using warfarin in obesity. So as I mentioned earlier, many practitioners often feel more comfortable utilizing warfarin in obese patients because of the ability to monitor an INR and have more experience with it. However, the use of warfarin in obese patients has not actually been extensively studied as well. And there are no current prospective or randomized controlled trials that looked at obese patients versus non-obese patients and looking at thrombotic and bleeding outcomes using warfarin. One interesting retrospective study that I did find was looking at a retrospective review of 211 patients that have been newly initiated on warfarin in the hospital. So they broke down the patients based on their BMI. So you can see here the normal BMI group, obese, and morbidly obese. And what they found was that morbidly obese patients and obese patients were statistically significantly less likely to have a therapeutic INR at discharge compared to patients with a normal BMI, so 71% versus 42% and 38%. Morbidly obese patients and obese patients also had a longer median time to therapeutic INR. So you can see here 6 days versus 10 days. So just keeping in mind that although we feel more comfortable often utilizing warfarin in these patients, we don't necessarily have clinical outcome data, and this kind of suggests that potentially warfarin acts and performs a little bit differently in obese patients compared to non-obese patients. So then I'll direct you back over to Slido, and I wanted to wrap up with a patient case to kind of incorporate some of the concepts that we talked about today. So a 48-year-old male presents to your anticoagulation clinic for routine INR monitoring. The patient has been on warfarin for atrial fibrillation, but is having trouble finding his rides to the clinic and finding it cumbersome to get to clinic every other week to monitor his INR. He's asking about alternative options, and which do you think would be the most appropriate? I have some of his objective data listed here. His weight is 153 kilograms, his BMI is 44, and he has normal renal function. Okay, so pretty unanimously, it looks like it is prescribed rivaroxaban 20 milligrams daily, and then some people would also agree with doing apixaban or rivaroxaban with a plan to monitor anti-10A levels in a week. So I would argue that I agree with the majority in the room that I think rivaroxaban would be a good option for this patient. I'll give a disclaimer that I don't think there's a 100% correct answer to this patient case, but based on some of the PK data we have regarding reduced exposure to dabigatran, I wouldn't want to really prescribe that in this patient. And then I think there's some feasibility issues with anti-10A levels, which is why I probably would not argue to monitor this regularly in an obese patient. So just to now kind of summarize some of the concepts that we talked about today about using DOACs in obese patients, I would argue to use with caution rather than avoid completely. And I think it really needs to be considered on a case-by-case basis whether a DOAC is appropriate for any specific obese patient. So some of the things that would go into this consideration would be the level of risk associated with subtherapeutic levels. So this would depend on the indication that the patient is receiving anticoagulation for, as well as their risk of bleeding as well. You'd also want to think about drug-drug interactions because these would be handled differently for DOACs versus warfarin. And then also, I think a big reason why you might argue to use DOACs in obese patients is if there's a concern for adherence with INR monitoring with warfarin, because this could also be suboptimal in obese patients. And then when it comes to monitoring DOACs, I would argue to reserve monitoring for patients with a high risk of treatment failure who cannot take warfarin. And I kind of offer this specification because if you feel like they're a high risk for treatment failure and you get a level, you're likely going to be switching them to warfarin anyways. So I don't know the utility of a level and spending money on a level in that situation. So keeping in mind that monitoring is expensive and it's often not available at University of Maryland, we do have this as a send-out test. It would be through LabCorp. So it wouldn't be something that you'd be able to get very immediately anyways. And then usual on-therapy ranges are not correlated with clinical outcomes, and there's no real clear guidance on how to use the levels if you do obtain them. So with that, that concludes my presentation. I'd be happy to take any questions or comments you may have.
you have a question, please use the microphone.
In the studies that you had shown with the different weight classes, a lot of them cut off at 80 kilos or 85, and there was that range between 85 to 120. So is that a gap, or what does that mean exactly for those patients?
Yeah, they don't really explain exactly why they did that, but I think that they were trying to make sure that they weren't encompassing anybody who had a high BMI. So I think that they were, they cut it off at 80 kilograms rather than going straight up to 100 kilograms, because some of those 80 to 100 would also be considered obese. So they were trying to look at patients with a high BMI, even though they were using weight as a cutoff. I think they were trying to compare a high BMI with what would be considered a normal BMI. But there wasn't a clear, I think that's my best guess as to why they were doing that.
I had a question floated on Slido. Would your recommendation change based on whether the indication is for atrial fibrillation or venous thromboembolism?
I think it would, based on the fact that, say, if somebody has an acute venous thromboembolism, you'd be a lot, so a PE or a DVT, you'd be a lot more concerned about having subtherapeutic levels compared to if somebody has atrial fibrillation. I think then you can also look at their risk individually as well. So if they have a very low CHA2DS2-VASc score, again, you might not be as concerned with subtherapeutic levels, but if they had a very high CHA2DS2-VASc score, then you'd probably put them more into the category of having an acute PE and being very high risk for thrombosis. So I would feel probably less comfortable with utilizing a DOAC in that patient.
Great job. Is there any guidance for situations where you might need to go with a reduced DOAC dose because of a different indication in the obese population? How would you kind of approach those sorts of scenarios?
So they still recommend to monitor concentrations in that population, and then so the ISTH guideline, that guideline recommendation statement has listed in their supplementary tables ranges for basically almost all of the doses. So say apixaban 2.5 versus 5, they have ranges listed. So I guess I would go and if you were to get a concentration, go to those tables and look at what the reduced dose range had been, keeping in mind that all of the ranges kind of are wide and they overlap for the most part anyways. But that's probably how I'd approach that. Okay, thank you, everybody.